I am muting everyone. Yeah.
Yeah, you can spotlight the chairman and the chairperson.
Yes, sir. Right. Now we are available on YouTube also. I have shared the link in the epilepsy group.
Link. Yeah, as well as on chat.
All right.
Sir, Dr. Pawan number is switch off. Dr. IUC has joined. Dr. Pawan number is switch off.
So good evening, all the respected panelists, doctors, and the quiz winners here in the panel box, and also the viewer doctors who are viewing this program over Zoom, and doctors who are viewing this program over YouTube. Today is the module 5 of epilepsy modules, and today is a very special day. We are recognizing the prize winners of quiz contest. Last 4 modules are there. So along with us, the quiz winners doctors are also there. So today, I'd like to request once again our organizing chairperson, Dr. Shifali Gulati, to come on the stage and start the session. Over to you, ma'am.
Thanks. Thank you so much. I thank everybody for joining, and I thank the chairpersons from first session onwards. And put the first certificate, please. So as we had decided in the first meeting that for every of the epilepsy models, we will bring prizes in 3 categories: one for the practitioner, one for the PG, and one for the neurology training. So we have had 12 of them. So we will be
Yeah. So thank you, Shifali, respected Shifali, ma'am. So I am showing the certificate because it's a virtual program, so we cannot hand over the certificate physically. So we have to be limited with our.
Thank you.
Professor Kalra will be taking.
Yes.
Professor Kalra will be taking for the first one. Can you put the slide share the certificates, and the MSers will come on your mobiles, by SMS.
Yeah. So we'll be sending. Now we are showing. Yes, we are sharing the.
Yes, certificate.
Ma'am, if you can. Yeah, if you just open your. Shifali, ma'am, if you open your video, I can spotlight you also. Without opening video, I cannot spotlight anyone. Yeah.
No. Is on spotlight, Dr. Kalra. Spotlight, Dr. Kalra.
Yeah, it is already done. It is already done.
Yeah.
So, the things are there. Now I am sharing the certificate owner of this module 1, 2, 3, 4 gradually. And yes, you can rather accept. There could be some small mistake. If you find it something like that, we will be correcting it because we have made it, and I hope we have taken enough care to make it perfect there. So I would like to request Dr. Madam Pina Karda to hand over this certificate to our respected.
Hello.
Yeah.
Did I just share the screen?
Screen नहीं आया
नाम से. आपके WhatsApp group में भी नाम है उनके. आपके WhatsApp में भी उनका नाम.
हाँ. Should I send the WhatsApp to Madam?
Put this.
My WhatsApp. मैं वो Excel sheet दिखाऊं? That would be better, ma'am. और certificate दिखाऊं?
Actually, the certificate is very well visible. So.
I think अगर certificates है ना तो आप सबके नाम announce तो कर दो पहले आप उधर से इकट्ठे. I think that would be better.
ठीक है.
Please announce all the names.
Just you can show the certificate
so that
and
then
announce.
You can focus on the recipient. Show the certificate once, one certificate, and then the names of all the winners.
Okay. So I am showing all the qualifiers for this quiz contest.
Sure.
I think your screen is not visible.
Yes, ma'am. Can you see the qualifiers?
Not yet.
Not.
Yeah. Can you see now?
No.
No.
Yes, we can see the screen.
You can
Yes,
see
we can see. Yes.
your names are also there.
Can't see the screen yet. Can't see the screen.
अच्छा, Bina ma'am, can you see?
Screen दिख रहा है.
No, I can't.
Madam, you have joined from the mobile or laptop?
Because
Mobile.
you can see.
Mobile. Then you the slide. It will be on the next slide.
Swipe करिए मैडम.
आप स्वाइप कीजिए मैम.
Uh-huh.
स्वाइप कीजिए, आ जाएगा.
It will be in the next slide. Swipe.
Okay.
Have you got it, ma'am?
Not yet.
आप स्वाइप कीजिए, आ जाएगा सेकंड.
Okay.
So could you get it, ma'am?
Not yet. It's just going saying waiting.
Okay. Maybe some network issue. It takes time to get visible. Can I read it out?
Possible.
Yeah, best thing is that you can read it out. Yeah.
नित्या जी, आप मॉड्यूल 1 बोलिए, नाम बोलते जाइए.
अच्छा.
Yeah.
मॉड्यूल 1 और कैटेगरी नाम बोल दिए, फिर वो मैम को फोकस करिए, फिर वो प्राइज विनर को. ठीक है?
Okay. So should I complete all these 4 or one by one? Module 1.
One by one ना.
Right.
इसके बाद सेकंड वाले में डॉक्टर सिंह ही आएंगे ना, फर्स्ट वाले
Sure. So, respected doctors, so let me take the privilege to announce our first award winner for this quiz module 1, which was commenced on 13th June, Dr. Ayushi Rathi. Dr. Ayushi Rathi has been qualified in the pediatric resident category. And in pediatric practitioner category, we have Dr. Gajanand Tanwar, sir is there.
नित्या जी एक सेकंड पहले, नित्या जी उसको आयुषी कहाँ से है बता दीजिए, उनको
केजी
ऑन करने दीजिए. एक करके.
Right. So when I'm taking name, if you please unmute yourself, you will be coming on limelight, right? If I take Ayushi ma'am,
वीडियो ओपन करो.
उसे अपने फोन तो विवेक नु बुला दियोगे.
Ayushi, put on your video.
yeah. Ayushi ma'am, yeah. Ayushi ma'am, focus, yeah, right now, perfect. So Ayushi ma'am is the owner, basically, as a pediatric resident.
So let's all clap for her.
AJ Somaya, MC Medical College, Mumbai. As a pediatric resident, Ayushi madam has qualified for this. And our next winner is Dr. Gajanand Tanwar. Dr. Gajanand Tanwar is from SP Medical College, Bikaner. Yes, one. Gajanand sir is now on spotlight.
Yes. Good evening to all.
I hope everybody will
Congrats.
Congrats.
Thank you.
Congratulations.
Thank you, ma'am.
And our third recipients of this quiz contest, Dr. Sridhar Popbhai Joshi.
Hello.
Yes. Sridhar sir.
Hello. Thank you.
Yes, sir. Sridhar sir is now on spotlight now. Sridhar sir belongs to CMC, Vellore.
Congratulations.
Congrats.
Thank you.
Sridhar.
Congratulations, Sridhar sir.
Congratulations to all the winners. I think you've done really well. And it's a very proud moment for all of you to get a prize in this quiz. And I think this will increase your interest in the discipline. And I think all of you will improve significantly in your practice. And also with the interacting and maintaining interest in pediatric neurology as a specialty. Congratulations to the winners of the first session. I can't see because I'm still not on screen, so I haven't been able to see anyone. But congratulations. Maybe you can go on to the next session now with Dr. Pratibhas.
Yes.
I can't. My screen is.
Thank you, ma'am.
Instead of having this,
Thanks
I
so
would
much.
rather you have one certificate and then, the certificate and the winner, being projected.
Yeah.
That would be better.
Actually, I'm on the mobile and it has still not come on the mobile. So I'm just trying to get my laptop and then start.
Pratibha,
But in any case, I think you start. Let's not spend more time on this.
Pratibha ma'am, we can show it. What do you say? At the same time, now I need one confirmation from all the contestants. I have shown the mobile number where I will be sending the actually the voucher, gift voucher that you have qualified for that. So if you find your mobile number is having WhatsApp, it is correct. It's fine. Otherwise, you can send me your correct WhatsApp number. The number I have mentioned at bottom, 9434030943. You can just
please confirm it so that the gift voucher doesn't go to the wrong person.
Yeah. So my another concern is there that you should check your own email ID and phone number that it is correct. So, so if you find if it is correct, it is okay. You need not to send anything. You can say it okay. Or if you find it's not correct, then you please send me your correct WhatsApp number and your name.
That's okay, Nityaji, but I think better for put the certificates. We've already made certificates, no?
Yeah.
So can you show? Yeah, you please show the certificates. We made the certificates module wise. Can you just show the first module certificate also fast, and then second module while Dr. Singh will start saying, "Ma'am ko dikha wal rakho." So that's why you said. So just show the first 3 candidates also certificates. We've already made them, right? Yeah. So just show them fast, and then come to the second module and Dr. Singh will call out.
Right.
I can see the screen. Yeah.
Right. So I am just sharing the certificate here.
Yeah. Take time.
It will one by one. It will come, ma'am. Actually.
Okay. No problem.
So our first recipient of certificate was Dr. Ayushi Rati.
दिखा दो.
अभी दिख रहा है ना, ma'am?
Yeah.
It's visible.
Yeah. Dr. Ayushi Rati. So we have already introduced Dr. Ayushi Rati. Veena, ma'am, you are there, na?
It's okay. You can go on now.
Okay.
Go on.
Yeah.
And our next was there, Dr. Gajanan Tanwar was there. And sir, you have been also qualified for this category of pediatric practitioner. And our third was Dr. Sridhar Obhai Joshi, the pediatric neurology trainee from CRC Value. So these are your certificate, and the voucher will be sent to your respective email ID, as well as it will be confirmed through WhatsApp, the number I have shown. Thank you.
Yeah, next you can continue. Module 2.
Module 2. Yeah. So can we have the winners of module 2?
Yeah. Can you see it, ma'am?
Yeah. I think we can straight go to the certificates.
Certificate itself, everything is available.
Yeah. So certificate and the candidate, and that would be better.
Yeah, Nityaji, certificate करके spotlight कर देना.
Right.
Okay.
Nityaji, certificate displayed on Dr. Singh and the recipient. He decided who was na.
So Dr. Aman is there, our next recipient for this module 2 session.
Nityaji, madam is speaking. Yeah.
So,
Madam.
Dr. Aman from AIMS Rishikesh. Yeah,
Spotlight.
good evening. Congratulations. Can we see you?
Yeah.
Yeah.
Congratulations.
So, many congratulations, and we hope that you will continue to have these laurels in the frequent next kind of meetings as well. Congrats. Keep it up.
Yes.
Next, please. So now we have Dr. Ayushi Rathi again. So is she going to have a hat trick? Ayushi? From
I'll try my best.
Sumaya Medical College, Mumbai. Yeah. Wonderful to see your name again. And I
Thank
do
you so
hope
much.
where are you? We are not seeing. I'm not.
Nitya ji.
1 minute. Yeah. Can you see it?
Yeah,
Yeah,
now
yeah.
we can see.
Congratulations.
So many congrats. Keep it up. And the young budding neurologists
so
have to
much,
come
ma'am.
up. Right. Okay.
Yes, ma'am. Thank you.
Dr. Deepa from Thanjavur Medical College, is it?
Yeah, Tamil Nadu. Yes.
Yeah, from Tamil Nadu. And where are you, Dr. Deepa?
Yes, ma'am. Good evening, ma'am.
Good evening. Good evening.
Yes.
Congratulations.
Thank you, ma'am.
And felicitations, and I hope that you will maintain your interest in pediatric neurology and have, all of you all will bring up
Yes, ma'am.
pediatric neurology in the future. Many
Yes, ma'am. Yes,
congratulations.
ma'am.
So congratulations
Thank
to
you so
all
much.
three of you all, and we do hope that these quizzes and these webinars will kind of motivate all of you to dwell further into the academics of pediatric neurology and take it on. Thank you very much, and once again, congrats
Thank you.
to all the winners. Bye.
Yes. So we'll go to module 3.
Yeah.
Thank you, Singh ma'am. Thank you.
Yeah. So this is once again, madam. Module 3. And Shifali ma'am.
नहीं आप ही बोल दो कोई बात नहीं.
It is.
बोल दो डॉक्टर अनूप नहीं है.
हाँ.
He's traveling. Yeah. Dr. Singh ma'am, can you please felicitate these also, ma'am? Dr. Anup Verma is traveling. He was the chairperson. Ma'am,
Okay.
ma'am, please. Thanks.
Fine. So is it Dr. Aman again?
Yes.
Wow. These people are really brilliant, huh? So congratulations, Aman.
Thank you, ma'am.
So do you want to show your face again?
Yeah, 1 minute, ma'am. Yeah, can everyone see?
Yeah. Wonderful. I think everybody should clap for you, and delighted to see that you are again people, you are just flooring everybody. Congratulations. Keep it up.
Thank you.
Next is Dr. Pawan.
Next is Dr. Pawan Gangoria from Jodhpur. Huh?
Yes.
Wow. So
Jabalpur. Jabalpur.
Jabalpur. Okay, I couldn't see the. Yeah. So it's Jabalpur. So can we see you, Pawan? Is he around?
Yes, sir, my video is on, but I am not able.
Yeah, you're just 1 minute, sir. Actually, sir, you have to change your name. First, I am changing your name. Yeah, I was just searching it out.
Okay.
You have joined from.
It's okay. नित्या जी उनका नाम बाद में बदल देना, अभी करके
हो गया.
Okay.
हो गया.
Okay.
हाँ.
अभी Dr. Pawan is there.
Yeah. Congrats.
Good evening, ma'am. Thank you, ma'am.
Good evening. So keep it up. All the best.
Thank you,
ma'am. He got this as a practitioner. But on 1st of July, he joined our division as a sponsored candidate for DM. So,
Achha. Okay, wonderful.
First he joined, yeah, he's here.
Achha. Great. That's even, speaks laurels for him.
Thank you.
Congrats.
Yeah, next.
Next is there.
Next, Dr. Arnab Samantha from the institution is Calcutta Medical College.
Ma'am, the spelling of my name is not correct. Ma'am,
Yeah.
the last word should
be
be
Arnab?
B. Yes, ma'am. Yes, ma'am. It should be B.
I beg apologies, sir. It has been corrected now. The right certificate will be sent to you. I know.
Arnab should have been Arnab B.
It should be.
Yeah.
It is there at the end.
Never mind. You'll get the corrected certificate.
It is already
Congrats,
corrected.
Arnab.
Thank
It
you,
is
ma'am.
already corrected, Arnab sir. Yeah, ma'am, please.
एक minute, Nitya ji, is this module 4? It's module 4. Dr. Anya has ma'am has also joined. Module 4.
So it is. So I hand over then to Dr. Satyendra.
Ma'am, बोलिए.
नित्या जी, ये मॉड्यूल 4 का विनर है, तो the chairperson will be different मैम.
Yeah, that's what I'm saying. Now module 4
Yeah.
में कुछ error है. कोई बात नहीं, आगे चलो, कोई बात नहीं. मैम ये announce कर दो.
Hardly matters. Okay. So now I've already announced Anna, and I hand over now.
Can you see the
to Dr.
correct
Satyendra.
certificate? Correct name has come.
No, it hasn't.
No. Correct
Not
name has
change
come.
नित्या जी, परवाह नहीं, चेंज नहीं हुआ.
आगे का please next please.
This is correct.
Yeah, correct.
This is correct name, yeah.
Yeah, correct. Now,
Ma'am, one thing is, ma'am, my institution name is Calcutta National Medical College and
Oh,
Hospital.
fine. One second. Any error, please WhatsApp. It will be done.
Okay, ma'am.
It was just idea to introduce
Okay,
you guys, get you blessed from
Sure,
our
ma'am,
big
sure.
stalwarts, and they agreed to come, and then we have today's session also.
Sure, ma'am.
Nitya ji, just continue to 4. There is another error. If it's a module 4, the chairpersons you've not changed. So anyway, we'll check it. It's
We'll change.
So all the best,
Yeah.
and
Thank you, ma'am.
congrats once again to the winners, and hand over to Dr. Aneja.
Last module, thank you so much, ma'am. Singhi ma'am, thank you very much. Fourth module, बताइए please.
Welcome.
Yes.
Yes, this is again Dr. Pawan. Yeah.
spotlight,
Dr.
Dr.
Anisha ma'am.
Yes.
Dr. Anisha ma'am.
Hello.
Yes, ma'am.
Good evening, everyone. So it's
Good
pleasure
evening.
to announce the name of Dr. Pawan. I think the spelling is maybe, I'm not sure whether it's correct. There is A missing according
It's
to
wrong.
me.
Ma'am, ये certificate
Yeah,
पिछले
so
एक
it is
घंटे में
corrected.
बने हैं, इसलिए गड़बड़।
So he has already been shown his face, and as Shefali pointed out that he was first a practitioner and now he has joined pediatric neurology training. So congratulations, Pawan. All the
Thank you.
best and God bless you.
Thank you.
Next.
It's a pleasure to see you all doing so well
Same
in
here,
your
ma'am.
quizzes. And I saw the level of quiz was quite good. And it had a, spanned all from the history to the current genetics. So it was excellent to see all of you winning these difficult quizzes.
Again,
All the
Arnab.
best. So the second winner is Dr. Arnab Samanta. Again, the spelling needs to be corrected. And the institution, he has already introduced himself, Arnab, that you are from Calcutta National
Yes, ma'am.
Medical College. So congratulations, Arnab.
Thank you, ma'am.
And
Thank you, ma'am.
keep doing as well as you have done this time. Keep it up.
Thank you, ma'am.
And he's in the category of pediatric practitioner. And then we have Dr. Sameer Bhatia, who has won this quiz from the category of pediatric practitioner, which is from Gangaram Hospital. Is it there are two practitioners here? Dr. Shefali, is he from which category? Sameer, you are from?
Good evening, ma'am. From
He's
pediatric
a
practice.
practitioner.
Okay.
And because Pawan moved out from practitioner to trainee, because he
Okay,
was
yes, yeah.
practitioner in June and he became trainee on 1st July. So
okay.
Stopped the degree.
So congratulations, Sameer. Good to
Thank
see
you,
you
ma'am.
all, and
And
God bless
I
you.
thank the organizers for giving us this opportunity and for such an innovative and interesting, educational content is being given to us. Thank you, everyone.
God bless you.
Thank you.
Okay, I think that's
Thank
the end
you.
of module 4.
Yeah. Yes, ma'am. I really am thankful to you, ma'am, for you joining from US. Thank you, Dr. Singh, and thank you, Dr. Kalra, for taking time out again and giving your blessings. Thank you so much. And we really thank Bravo Bliss for sponsoring the quizzes. And Saji, 30 seconds because we are running late. Before we start
I thank
the
everybody.
session.
I thank Dr. Shefali ma'am, Dr. Pratibha Singh ma'am, Dr. Aneja ma'am for being a chairperson for this event, and a
Dr. Kalra
wonderful
also.
educational feast.
Thank you.
Dr. Kalra also. So it has been a wonderful session all through, and good luck for further sessions and extended sessions also. All the best.
All the best, everyone. And great going.
Ma'am, before you, Yeah, thanks, thanks Sujata, thanks a lot. Before Dr. Singhi ma'am, Kalra and Taneja leave, we would be very happy to continue for the session, but I just wanted to say that on popular demand, we have extended the module by 2 more sessions. One will be focusing on EEG and the other.
Ma'am, you have to repeat it once again. You are not
because
audible.
आपका audio cut हो गया.
Yeah, one would be for the practitioner EEG, and the other would be on neuroimaging and other investigations. So I thought that we are extended by 2 sessions on popular demand. And thank you so much for all your support for all participants. Thanks. And we start the session for today. And can I have the slide for Dr. Vivek Talukdar's CV, please? I'm really grateful that Professor Vivek Talukdar has agreed to chair the session. He has also been one of the pioneers of pediatric. He was, heading in MAMC and Chacha Nehru Hospital, and he's also been associated with the Association of Child Neurology as a founder member, and he has been there, working in child neurology, and has a book also in child neurology. So thank you so much, Professor Talukdar, for joining in. And Dr. Anup Kumar would be introducing Dr. Ramesh Konanki.
Yeah, thank you, ma'am. Next slide, please, Nityaji.
Yeah, slide is there, sir. Can you see it, sir?
Yeah. I welcome Dr. Ramesh Konanki. He is consultant pediatric neurologist. He has done MD Peds from AIMS and DM pediatric neurology from AIMS as well. He is presently affiliated to Department of Pediatric Neurology, Rainbow Children's Hospital, Hyderabad. He has also presented scientific papers at international conferences held in Daegu, South Korea, London, Iguazu Falls, Brazil, Mumbai, and San Diego. He was an active member of a nationwide multi-center study on childhood neurodevelopmental disorder being conducted by International Clinical Epidemiology Network, that is INCLAIN. He has 42 publications in various international peer-reviewed scientific journals. He has authored 10 book chapters as well. So I welcome Dr. Ramesh Konanki. Over to you, Shifali ma'am.
Over to Professor Vivek Talukdar and Dr. Ramesh Konanki. Now we'll just come in by time.
Thank you, Dr. Shifali, so much. So, shall I introduce the Goswami, Shifali?
Yeah, Dr. Goswami.
Goswami is assistant professor in Department of Pediatrics, Army Hospital, RR, New Delhi. He has got, he is MD Pediatrics, DNB, DM Peds Neuro from Nimans, MS. He has about 45 publications. He has research, is undergoing research in PI into multicentric RCTs. Areas of interest of Dr. Goswami is pediatric epilepsy, neuromodulation, pediatric movement disorders. I think, Dr. Shifali, you can start this session without wasting any time. We are already late.
Yeah, Goswami sir,
over to Goswami. You can start the job. We have a very interesting topic, the neonatal seizures. The topic appears to be a little bit of devious from what a neurologist usually continues to be there. It's a very interesting topic, very perplexing many times, and early diagnosis is very important for prevention of future morbidities and mortalities and sequelae. Dr. Goswami, please continue.
Thank you, sir. Am I audible?
Yeah, you are audible to me at least.
Good evening, everyone. At the very outset, I would like to thank Professor Shefali Gulati ma'am and the team of organizers for giving me this opportunity to be a part of this academic feast. It is an onerous responsibility with so many doyens of pediatric neurology present today, including my mentor, Professor Singhi ma'am. So without wasting time, I start today's presentation, where the aims of the presentation would be to give an overview of neonatal seizures from the perspective of a pediatric neurologist. I would sensitize the residents about the basics, give the nuances of history, clinical examination, and investigations while managing neonatal seizures, the management algorithm as presently accepted by the various consensus groups, and certain current perspectives. So, as Professor Talukdar has already told, and neonatal seizures is still an uncertain territory. Even the definition is into controversy. So, the reference which has been taken today is the ILA consensus, the task force paper, because it keeps on changing. I'll come to the reason why in the next slides. So normally, by definition, neonatal seizures or any seizures are basically sudden paroxysmal change in neurological function. And this neurological function refers to motor, sensory, autonomic. However, in pediatric, in neonatal age group, there are certain differences which we'll cover. It is associated with abnormal synchronous discharge of cortical neurons, and the cutoff which is taken is post-menstrual age for 44 weeks. It is not just 4 weeks of life, so that even the preterms are catered for. The incidence of neonatal seizures is pretty high across various reports, going from 1 to 5 per 1,000 live births, and the commonest incidence is in the first 7 days of life. Certain peculiarities of neonatal seizures are very striking. For example, it is focal, because for a seizure to spread, there has to be a network. And because of the poor myelination, because of the immature myelination, the neonates don't have generalized seizures. So that is the number one point. The second thing is that in the neonatal brain, the excitatory circuits are more conspicuous. We all know that glutamatergic receptors are excitotoxic, and GABA is responsible for inhibition. However, in the neonatal brain, there is a decrease in the GABA receptors, as well as certain GABA receptors are excitatory mediators. The drug handling mechanisms vary due to the variable absorption, variable receptor sensitivities. Hence, the drugs which are given in neonatal age group may have altered functions. And there are certain developmental effects of anti-seizure drugs. For example, phenobarbital, phenytoin, valproate, they can have apoptotic effects long-term, leading to developmental side effects, which are coming more and more into light of late. So how does a clinician approach a neonatal seizure? So the first question which has to be answered is whether the neonate has a seizure, or the movement which is under question is a non-seizure. In case there is a seizure, what type of seizure it is? And then comes the question whether we can find a probable or definite cause for the seizure. The tools which are at the disposal of the clinician are history taking. History taking never takes precedence over emergency stabilization. Emergency stabilization is number one. Then, in case a baby has come from a different hospital, or has you have been called to look at the baby in the NICU, then obviously a brief but meticulous look into the medical record. Observation of the seizure semiology gives a lot of clues, and it may be real time or on a video record, clinical examination, and certain ancillary tests. Diagnosis is important. It is important because first, as has been told 2 slides back, we have to know whether it is a seizure or not a seizure. And identification and treatment of an underlying disorder giving rise to the seizure, and prevention of additional seizures, which can have detrimental effects on the brain, and seizure-related complications, systemic complications such as cardiorespiratory imbalance, as well as to prevent excitotoxic long-term brain injury. So because of all these reasons, diagnosis is very important. Then the questions which come to our mind are what investigations to be ordered, what drugs to be given, how long have the drugs to be given, how do we counsel, and are there any roles of genetic counseling and specific tests? So before we go into dive into the presentation, just have a look. This is a neonate who was found to be having these sort of movements. And when the baby was woken up, the movements vanished. Otherwise, the perinatal transition has been uneventful. So this goes quickly that the baby was born uneventfully and the baby had these movements. So this is benign neonatal sleep myoclonus. On the other hand, this baby also has similar movements. However, the baby, as you can see, has got an IV line, EEG is being monitored, the baby is on the ventilator, and there is a change in the breathing pattern when the baby has these movements. These are seizures. The definition of seizure is quite simple when you look at it. However, on clinical grounds, defining seizure may not be that simple. Epileptic movements generally do not increase with sensory stimulation, unlike non-epileptic movements. And restraint for the junior residents, I would mean to say that mild, you can use your finger or some mild force to counter the movement which is happening at a particular limb. So restraint stops non-epileptic movements. And autonomic accompaniments like flushing, sweating, change in color, these are more common in epileptic movements. So a lot of studies have gone into the differentiation between epileptic and non-epileptic movements. And besides what has been told in the earlier slide, automatisms, which are movements which look synchronous, but they are not volitional. For example, cycling movements, chewing movements, recurrent ocular movements, apnea. So these have been seen in neonatal seizures. So at this point, I would like to cover 3 or 4 important non-epileptic movements. The commonest is jitteriness, which is a sudden jerking of the limbs. Normally, this you see when a baby is being suddenly exposed, the clot has been taken off from his or her body, or a light has been put on, there is some sound, there is a clonic jerking of the limbs, and there is a tremulous movement of the limbs, unlike seizures, where it is clonic. Clonic means a rapid contraction followed by a slower relaxation. And the jitteriness ceases when it is restrained. There are no autonomic changes, and there is no abnormality of gaze or eye movement. Benign sleep myoclonus, as the video had been shown earlier, had been found to be repetitive and synchronous. Interestingly, if in case it is interpreted as a seizure and benzodiazepines are started, there is no effect on the myoclonus, and in fact, it can get exacerbated. Generally, by 3 months or so, these abate, but sometimes it may continue beyond that also. This is hyperepilepsia, which is a relatively rare phenomenon where it is basically exaggerated startle, and it is a non-epileptic movement, which is due to certain mostly autosomal dominant, rarely X-linked recessive mutations. GLRA1 and SL6A5 are the commonest mutations, and these exaggerated startles can mimic tonic seizures. They can sometimes be very dangerous also. So forced trunk flexion, which is known as a Viger-Banous maneuver, or clonazepam, have been used as treatment in these movement disorders. Historically, seizures in neonatal age group were defined into 3 categories. The clinical ones, where there is no EEG abnormality, it is only clinical. The electroclinical ones, which have an EEG correlate, and electrographic ones, which have only EEG abnormality with no clinical signs. There was an argument that subcortical structures, limbic structures, can propagate seizures without any cortical involvement and hence no EEG abnormality. However, this is being questioned more and more of late. Movements like tonic posturing, maybe limbic movements without seizure activity going on. So the ILA classification, which was told in the second slide also, so presently says that neonatal seizures have a great role of EEG in its diagnosis. Secondly, since they are focal at onset, a division into focal and generalized is unnecessary, as in the case of seizures in older children. And there can be motor, non-motor, and sequential seizures. These sequential seizures are seizures where there are varying manifestations in the same seizure. For example, a neonate may have a little bit of clonus, then the neonate may have some myoclonus, some tone abnormality in the same seizure. If a neonate has 3 types of seizures, say myoclonus now, a tonic seizure after 4 hours, then it is not a sequential seizure. This is a very comprehensive pictorial diagram which shows the etiologies of seizures in the neonatal age group, where hypoxia and structural have been kept at the top, and the seizures have been classified into motor, non-motor, and electrographic seizures. Epilepsy syndromes are certain known epilepsies in neonatal age group which have a definite clinical and EEG correlate. For example, EIEE, which is quite difficult to control. And this diagram gives a visual impression of the quanta of etiologies that is responsible. For example, the HIE blob is quite big, whereas the brain malformations is relatively smaller. So these seizures for bedside clinics may be divided into the ones which have been shown in the slide here. Subtle seizures do not look like seizures. They may be some behavioral issues, like a baby who's suddenly stopped his or her activity which was going on, some ocular phenomena like looking towards one side or staring blankly ahead, certain chewing or sucking movements, alternate cycling movements, along with autonomic movements. Clonic movements can involve the limbs, either of them. There can movements of the eyes to a particular side and return to the baseline. There can be trunk myoclonus also. And tonic movements or tonic seizures, and tonic eye gaze is also taken as seizures are sudden shock-like movements less than 100 milliseconds is the cutoff which has been accepted internationally. Upper limbs are involved generally more than the lower limbs. There can be multiple myoclonic movements of either limbs occurring in a non-random fashion, or there can be simultaneously occurring in 2 limbs. There is generally an EEG correlate. So broadly, we have subtle, clonic, tonic, and myoclonic seizures. Automatisms may be either unilateral or bilateral, as has been told earlier. They are synchronous movements. They appear volitional, like cycling. However, they are actually not volitional. Epileptic spasms, we all know, can be flexion, can be extension, can be mixed. However, rarely, it is generally these take place in the infantile age group. And only in certain epileptic encephalopathies do we have epileptic spasms in the neonatal age group. What is an EEG seizure? So for this, as ma'am had told in the beginning that there will be an EEG module, we are not teaching EEG here, but just focus on these lines where you see something is happening here. Basically, what is happening is the seizure is, the electrical activity is evolving. And the guideline which has been now taken internationally is that there should be a repetitive electrographic abnormality which should evolve in amplitude, frequency, or location with minimum 2 microvolts peak to peak voltage, and the duration should be at least 10 seconds. There is something known as BIRDS, which is brief interictal repetitive discharges. So these are not taken as, these look like abnormalities, but they are not taken as seizure. And the cutoff is 10 seconds, which has been accepted now. So here we take a break from the talk. Here the child, the baby appears to be cycling with the hands. There is also a gaze of the eye to the left upper. Here there is some fragmented myoclonuses happening, lower limbs, some clonic movement also. So a lot of seizures happening here. This baby is also having tachycardia. That baby is presently throwing a seizure. Unfortunately, so this baby, though in the NICU, had these movements. On waking up, these movements used to disappear. So this, and it was not associated with any electrolyte abnormality. The baby on follow-up is having a normal neurodevelopmental outcome. This looks like a benign sort of a movement disorder. There has been a study of benign myoclonus, and around 534 babies had been studied in the US, where it was found that generally by 3 months of age, most of them abated. Here again, in this video, again, the baby is having certain movements of the lower limbs, which is more like a focal myoclonus. So when a baby presents to the neonatologist or the pediatrician or the neurologist and the baby is critically ill, if there is a clinical suspicion, now the consensus is that the baby should either have an EEG or the baby should be fitted on a continuous EEG monitoring. And when there is an EEG correlate along with seizures, there is no doubt that the baby has got a seizure, and then the seizure is classified into the ones which have been shown on the chart in the left lower. Without clinical signs, only EEG problems, then it is taken as electrographic seizure. However, if there is no EEG correlate, then they are taken as non-seizure episodes. The probable etiologies can be divided based on the temporal profile. For example, on day 1, HI is the commonest. Day 2 to day 3, again, HI and hypoglycemia. These are found in all standard textbooks. The etiologies, as has been propagated in the Western literature, are flashed on the slide. HI rules the roost with 50 to 75%, and epilepsy syndromes and IEMs consist about 1%. Maybe they are under-recognized also. CNS infection, though taken from a standard textbook, says around 5%. Probably this number may be higher in resource-limited countries. So once we see the history and medical records, then we need to go into the clinical examination. The history has to be targeted for probable etiology. For example, HI, any difficulty in delivery. Reversible etiologies have to be kept in mind. Reversible etiologies mainly comprise of the metabolic abnormalities like hypoglycemia, hypocalcemia, and hypomagnesemia. And maternal history is equally important. Any drugs given, any withdrawal from any drugs, things like that. So suppose we have a 2-day-old term male neonate who weighed 3.2 kgs at birth with a good with an Apgar score of 9/10, having focal seizures from day 2 of life. The possibility here, the whole gamut of possibilities may be present, but probably the baby had an IVH or the baby had a stroke due to whatever reason. And after investigation, it makes me wiser, the baby had a perinatal stroke. A 7-day-old female neonate born to a G2 mother, delivered at term after an uneventful period, tonic seizures from day one. The mother, on being repeatedly asked, says that she used to feel that the baby was kicking incessantly in utero. This baby had non-ketotic hyperglycinemia. Even certain difficult or refractory vitamin-dependent epilepsies like pyridoxine-dependent epilepsies may have intrauterine seizures. A 20-day-old male neonate born after 29 weeks of gestation with a birth weight of 900 grams only had a stormy first 3 days with respiratory RDS, mechanically ventilated, seizures started early, had hypoglycemia, became seizure-free. Again, seizures started on day 20. Here the causes are probably sequelae of what happened in the early life, hypoglycemia, hypoxia, leading to brain injury. So these vignettes have been shown to show that the history is important, the onset and the pattern of seizures is very important. Similarly, a 20-day-old male neonate seizures on day, I think there is an error here, 3-day-old male neonate seizures on day 3 of life with low ionized calcium. So the neonate became seizure-free, so the baby had hypocalcemia. The calcium, on the other hand, continued to remain low. Despite giving calcium, hypomagnesemia has to be kept in mind, and the parathyroid axis has to be looked into. The gold standard currently is the continuous EEG. However, continuous EEG may not be possible for 24 hours, so it is recommended that at least 3 hours of EEG monitoring has to be done, along with video monitoring. However, in the NICU, it may not be possible to do a CEEG, so at least an amplitude integrated EEG, which is a compressed EEG, time compressed EEG, which gives an idea about epileptic events taking place. I'll show a picture in a subsequent slide. EEG is useful because it leads to a large yield of electrographic seizures, especially in sick babies, like babies who had HIE, who had a stormy perinatal period, who may not be manifesting clinically any motor abnormalities, but may be having seizures. Outcome can be prognosticated through the EEG. For example, a very bad EEG like a burst suppression or a burst attenuation pattern may be associated with certain diseases, certain epileptic encephalopathies who have a bad prognosis, and the severity of brain dysfunction is also known. So this is the burst suppression pattern which was told of. So the positive predictive value of amplitude integrated EEG is around 78%. This is a chart which has been beautifully given by the ILA task force. It may be applicable in certain centers where EEG is not available. If the EEG is available, then the question is answered. If the EEG is not available, the neonate, after being observed by experienced personnel, have been found to be having certain focal clonic or tonic movements, then we can just label as probable diagnosis of seizure, and accordingly, we need to follow up and we need to get an EEG. So the crux of this chart is that EEG is strongly recommended in the armamentarium of diagnosis of neonatal seizures. What is the role of neuroimaging? If a baby is very sick, then bedside ultrasound can be done. It basically picks up intracranial hemorrhage, major malformations like holoprosencephaly and things like that. In case a cerebral edema is there, so here an USG has picked up bleed. We have a 7-day-old female neonate who was born full-term normal delivery, who had history of 1 day of decrease in feeds, lethargy, and seizures, hypotonia, and minimally responsive state on examination. Investigations were normal and no focal signs were found. MRI was done, which had shown hyperintensities in the sinuses. The baby had a neonatal cerebral sinovenous thrombosis. Later, it was found that the mother had a connective tissue disorder and the baby also had the same. So neuroimaging is important in neonatal seizures. This is a good resource which I am flashing. CT has its obvious advantages of being rapid and quick identification of bleed, and obviously the expense factor, but MRI gives better delineation of parenchymal lesions. However, it requires anesthesia and sedation support. It is prolonged, may not be available. A 15-day-old male neonate delivered at home, lethargic and poor feeding from day 2 of life and seizures from day 3, daily 5 to 6 seizures, had this MRI. The baby was born at home and was lethargic. So probably the baby had hypoglycemia. The parieto-occipital involvement gives an indication of hypoglycemic brain injury. This again would be elucidated further in the radiology modules, which would be done subsequently. A neonate with seizures from day 1 of life, born at term with a birth weight of 3 kgs, normal glucose, electrolytes, refractory to all the drugs. So these are cystic changes everywhere. Baby had a molybdenum cofactor deficiency. So the story here which I want to show is that the MRI can give an indication about common conditions, rather not an indication, rather validation of common brain injury causes like hypoglycemia and HI, as well as uncommon ones like MOCO deficiency. CT has to be advised in case you have a setting of birth trauma, forceps being used, which are being used very rarely nowadays, any bleeding diathesis that a baby may have. And in case of persistent seizures, some clues like neurocutaneous markers or an abnormally large head size or dysmorphism or no other causes found, then MRI would be advisable. When to do a lumbar puncture? In case one suspects intracranial infection, you have a sick, very sick neonate or sepsis, and certain conditions like non-ketotic hyperglycinemia and pyridoxine-dependent epilepsy, these are refractory. You suspect refractory condition, and then these particular metabolites can be thought of. Even neurotransmitter disorders, I have not shown it because it is not available very frequently, but otherwise neurotransmitter levels are also being done in the West. Other investigations, the list goes on. That's the final word which has been written in the slide. So you have got a whole list, but then it's not like giving a battery of tests to everyone. It has to be individualized and stepwise. The need for further investigations have to be always guided by clinical markers. This again is an automatism which the baby is having. This is a baby who was born to a consanguineous couple, having seizures from day 4 of life, kept on having acidosis without any cause. This is a bigger baby. This is a representative photograph, not the one which had. So this baby had turned out to be biotinidase deficient. So metabolic causes, you think of when you have a family history, a history of consanguinity, and certain red herrings like certain vomiting, recurrent vomiting, acidosis, unexplained encephalopathy. In case you have clues like organomegaly, then you think of metabolic causes. Genetic testing, there is no consensus as of now to when to ask for genetic testing because you may end up with just a variant of unknown significance. However, if you have strong family history, dysmorphism, and you have a signature clinical pattern like early onset refractory seizures in non-ketotic hyperglycinemia, a baby who has responded to pyridoxine dramatically without any other issues, then you may think of a vitamin-dependent, pyridoxine-dependent condition. So genetic testing would be handy in these. Initial management, as has been taught from our MBBS days, remain the same. Initially correction of hypoglycemia, after securing the airway, breathing and circulation, of course, hypoglycemia, then hypocalcemia, and then hypomagnesemia. Hypoglycemia, you can document by a stick, and hypocalcemia by an ABG. In case you don't have an ABG machine, and in case there is no time to do it, after glucose, you can, if the seizures continue, you can give calcium correction. But nowadays, ABG machines are available in most of the places. Drug of choice has not changed much. The algorithm goes from phenobarbital to phenytoin or fosphenytoin. The dosages shown here, the first 20 is the loading dose, and you can repeat it 10 and 10 again. And the list goes on, which I'll tell about in the subsequent slides. This algorithm shows the management of seizures in newborns. Sugar, if it is more than or equal to 45 milligram, then you take it as normoglycemia in day 1. Measure the serum ionized calcium, correct it. If it is more, if the calcium is also more, then you go straight away to phenobarbital. Otherwise, you follow this algorithm. Once you have given phenobarbital, 2 dosages, it continues to seize, then you go to phenytoin, then you can go to lorazepam or midazolam, and levetiracetam has come in here. So these are the dosages. But unfortunately, the cessation of seizures is pretty low. With both phenobarbital, the range is from 35 to 40%. And the second one, I have written 2 because these are from 2 different studies. Unfortunately, I have not written. So basically, it can be anywhere between 30 to 70%, varying reports. Phenytoin up to 85%, and lorazepam gives a quick control. However, it is not for long-term control. Vitamin-responsive seizures are being increasingly recognized. Among them, pyridoxine dependence is pretty common. Here, you either do pyridoxine IV dosage under monitoring, because if suddenly giving a stat dose of 100 mg of pyridoxine can lead to apneas, you need to have your resuscitation kits with you. In case that is not possible, or you have given dosages and you find that the child has responded, then you shift over to oral pyridoxine. There is a category of newborns who have PNPO mutation, where a next step in the metabolite circle, pyridoxal 5-phosphate, has to be given. It is available either in tablet form or in certain supplements. Folinic acid is associated with folinic acid responsive epilepsies, and biotinidase deficiency has been told about earlier. B12 deficiency can also lead to vitamin responsive seizures. The response to anti-seizure medications in neonates has been recently seen. It has been seen that the risk of incomplete response was highest due to intracranial hemorrhage and lowest due to HIE. This has been a study which was published in Epilepsia, and a cohort of 534 neonates with acute symptomatic seizures were seen. The newer anti-epileptic drugs, among the newer ones, levetiracetam is being off-label, is being used more or less in an increasing fashion, more in an off-label fashion, because still date it has not entered the guidelines. Topiramate is neuroprotective. Both levetiracetam and topiramate do not have apoptotic effects on the brain, and they are therefore being supported. However, unfortunately, topiramate does not have an IV formulation. A systematic review of the efficacy of levetiracetam and neonatal seizures was done in Neuropediatrics 2018, which had shown that levetiracetam may be at least as or more effective as phenobarbital. On the other hand, there is a trial which is known as a NeoLEV-2 trial, which was published in Pediatrics in June 2020. It is a multicentric comparison between levetiracetam and phenobarbital for neonatal seizures. Here, it was seen that phenobarbital was more effective than levetiracetam for the treatment of neonatal seizures, and however, certain adverse effects like excessive sedation was common with phenobarbital. So we are still there. We are still where we were earlier, that phenobarbital is number 1. As of now, we cannot support levetiracetam as the number 1, except that it is supposed to have some neuroprotective role. How long to give the anti-epileptic drugs? Neonatal neurological examination will determine how long. In case it is an acute symptomatic condition, the baby should be off anti-epileptics when the baby has been discharged from the NICU. And the EEG will be a guide in that, for example, a neonate is hypotonic, has got a burst suppression pattern. We could not find anything in the investigations. Of course, the anti-epileptic drugs has to continue. So in case it is a transient metabolic issue like a hypocalcemia, the anti-epileptic drug is to be stopped immediately. Otherwise, the reassessment. So if we skip these part and go directly here, the reassessment is at 3 months when we decide on tapering and stopping phenobarbital. It is an individualized decision, and prolonged therapy is required generally in HIE, intraparenchymal hemorrhage, infarct, and metabolic and genetic conditions, and of course in vitamin-dependent epilepsies. There are certain controversies in neonatal seizure management, as has been brought out aptly by this resource. One of them is the discontinuation of anti-epileptics, because it is still open to debate and consensus. Then the second one is seizure recurrence versus the drug adverse effects. So the prognosis depends on the etiology largely. HIE patients, depending on the level of HIE, whether it is 1, 2, or 3, have a poor prognosis. And these seizures, like benign familial neonatal convulsions, the fifth day fits, which used to earlier be associated with hypocalcemia and things like that, now they have found that it is probably a sodium channelopathy. These have good outcomes, and hypoxic HIE has bad outcomes, and hypocalcemia, the later onset ones, generally have a better outcome. In case a neonate has a normal EEG, the neurological sequelae tends to be low. In case the EEG abnormalities are very severe, the neurological sequelae would generally be bad. The gestational age similarly has an effect on the outcome. The follow-up plan has to go through the early school years ideally. However, it may not be possible unless you have a good neonatal neurodevelopmental clinic followed by transition to the pediatric neurology services. The salient points which have to be seen are the clinical outcomes, the seizure cessation, the neurodevelopmental evaluation using a validated score, any cognitive defects, any physical abnormalities, and of course the parent as well as the family has to be educated about the seizures. With this, I would like to give the following carry-home messages to the pediatricians. One is that neonatal seizure is a very common entity. You have to beware of seizure mimics and differentiate between seizure and seizure mimics. That's the first part of the battle. Stabilization always takes precedence. You cannot take a 1-hour history when the baby is going downhill. There is a definite role of history and clinical examination and targeted investigations. EEG is very important, so we need to be sensitized towards neonatal EEGs. The management algorithm has to be imprinted in our minds and pasted in places of neonatal seizure management. Think of metabolic dysregulation first because it is treatable, and you need to have a definite follow-up plan. With this, I come to the end of this presentation. Thank you so much.
Thank you, Dr. Goswami. It's a beautiful presentation covering the history, the clinical areas, motivated and proper appropriate guideline for management down to the outcome. Very well, and you have covered everything so well. Very nice with you. Thank you so much. I think we can have a few questions if there is any.
Sir, we'll have both the talks over and then we can have questions, sir.
What is the your voice is not very clear.
Sir, we can take questions after both talks are over, sir, together.
Yeah, we can. Dr. Sefali. All right, we can take questions after this second session. Okay.
Thank you, sir.
Continue.
Yeah, over to you, Ramesh, sir.
Yeah,
over to Dr. Punagi.
Good evening, everyone. So I now invite Dr. Mahesh Kamte for his talk on seizure mimics. I feel happy and proud to be introducing Dr. Mahesh, who was my senior colleague at All India Institute during training. Not only as a senior, but a very good friend and a good human being. And he continued his interest in research, academic activities, and every aspect related to pediatric neurology. And he was the first DM pediatric neurology from All India Institute of Medical Sciences. His specific areas of interest being pediatric epilepsy, metabolic disorders, micronutrient deficiencies, and the relation to neurological problems, mineralizing angiopathy, and he has more than 90 indexed publications in PubMed and book chapters to his credit, and he has been awarded Best Young Scientist Award at his institute, KLE University, for the year 2013. And currently his research areas of interest include genetics of NCL. He has published an excellent paper of spectrum of neuronal ceroid lipofuscinosis from his center, more than 50 cases, B12 deficiency, epileptic encephalopathy, genetic aspects, autoimmune encephalitis, and spastic paraplegias. Dr. Mahesh, yeah, you can start your talk.
Mahesh sir, unmute yourself.
Yeah, very good evening to all of you. At the outset, I'd like to thank the organizers, especially Academy of Pediatric Neurology, IIP Dehradun and IIP Aligarh, and Dr. Shefali Gulati ma'am for giving me this opportunity, and Dr. Ramesh for the kind words of introduction. After having listened to a talk on neonatal seizures, we'll move to the topic of seizure mimics, which are also called as non-epileptic events. The term conversions, fits, and seizures are used interchangeably to describe episodes associated with involuntary motor activity. It's important to understand these terms because when a parent or a relative comes to you with a child, he says that my child has got a fit or my child has had a conversion. So we should know that when a child comes with this complaint, whether it's a real seizure or a non-seizure. Okay, not everything that twitches or jerks is a seizure, and not every loss of consciousness is a seizure. Non-epileptic events can also produce recurrent paroxysmal changes or consciousness or behavior that are similar to epileptic seizures. Non-epileptic events can be due to physiological or exaggerated physiological responses, sleep disorders like parasomnias, movement disorders, behavioral or psychiatric disturbances. They are more likely to occur in children with epilepsy and are likely to be affected by anti-seizure medications. Most of them are benign. They resolve spontaneously with time and do not carry the prognosis or stigma attached to epilepsy. It's important to note that few of these have got specific treatment, and if you diagnose correctly, we can treat them correctly. Wrong diagnosis of epilepsy is very common. Even in centers, especially in epilepsy, almost 20 to 30% of children have been misdiagnosed as epilepsy. This percentage is astonishingly consistent across centers, countries, and continents. What happens when a wrong diagnosis of epilepsy is given? It gets easily perpetuated without being questioned, which explains the usual diagnostic delay and its consequences. Many children are put on multiple anti-seizure medications with the associated side effects, and in some cases, there can be delay in the correct diagnosis by even 7 to 10 years. The events which can be considered as seizure mimics can include those with unusual movements like self-gratification, shuddering, benign sleep myoclonus, startle responses, paroxysmal torticollis, self-stimulated behavior, tics, chorea, paroxysmal dyskinesia, psychogenic seizures, and unusual movements. They can present as disorders of loss of tone or consciousness like syncope, drop attacks, or attention deficits. They can present with disorders of respiration like apneic attacks, breath-holding spells, or hyperventilation. And some of them can present with perceptual disturbances like dizziness, headache, and abdominal pain. Even behavioral disorders like head banging, night terrors, sleepwalking, nightmare, hallucinations, rage, confusion, fear can mimic a seizure. We'll see the one highlighted in red are the common conditions what we see in our practice. We'll try to see a few of them with cases. Okay, this is a case was shown by Dr. Goswami also. This is a 15-day-old neonate presenting with jerks during sleep, had a normal birth and perinatal history, and was accepting feeds very well. If you look at this video, you can see that this child has got this recurrent jerking of all the 4 limbs. It can affect all the 4 limbs, or can affect mainly the lower limbs and then spread to the upper limbs. The key thing is, if you look at the eyes, no, this child is sleeping. The moment baby wakes up, okay, like example, the child has woken up and the child is crying, and the moment will stop. So this is a benign sleep myoclonus, which occurs usually in the NREM part of sleep, can affect both proximal and distal parts of the body. It occurs every 2 to 3 seconds and can go up to 1 to 3 minutes also. It typically migrates from one part of the body to another and occurs bilaterally. It usually stops when child is awakened. Sometimes this can continue even in, sometimes we have older children who can have jerks during sleep, and they're called as hypnic jerks. Sorry, could not play the video. We'll move to another case. This is a 7-month-old baby who has abnormal movements for last 1 month, occurring multiple times a day. You can see this here. Usually occurs when the child is awake. See this? Child has got this stiffness of the back and stiffness of the neck with twisting of hands. And the child has this multiple events in a day. Usually, there is no loss of consciousness. There is no post-event in confusion or lethargy, and no other complaints. Child is thriving very well. This is another child. You can see that just makes the back stiff, extends his limbs, twists his hand, and there is some grimacing. Okay, so these two cases indicate the shuddering attacks. Okay, they're typical benign neurologic events that occur during infancy. The clinical event consists of rapid shivering of the head, shoulder, and occasionally the trunk. Events have been reported as brief, usually lasting not more than a few seconds, and the frequency can be very high, up to 100 events per day. Like seeing this video, in the just 1 minute, child has made more than 10 events. The intensity usually decreases in frequency, and usually they end by the first decade. They are quite benign and they don't need any treatment. Just reassurance is enough. This is another case, 10-month-old boy who presented a history of loss of consciousness with limb jerking, 4 episodes in last 1 week. Nowadays, many parents carry smartphones, and many of them get the videos to us. Okay, so this is the video which was shown to the doctor. You can see this child has got a tonic posturing of limbs. Okay, and this tonic posturing of the limbs is followed by episodes of jerking of all the 4 limbs. You can see here, this child has got these jerks. Looking at this video, because this child has a tonic phase followed by these few clonic jerks, a diagnosis of tonic-clonic seizure was made, and the child was started on carbamazepine by the general practitioner. So, what do you think? Is it a case of seizure or is it a seizure mimic? So, as is true in pediatrics, even in neurology, especially in seizures, you should always ask what happened, what was the child doing before the event. Okay, a detailed history should be taken, how it started. Okay, so this is actually event which is recorded in the video EEG room. So I'll play the video from beginning. Okay, you can see here the child is on the mother's lap here. Okay, for some reason child started crying. Okay, and as the baby cried, okay, then the baby held his breath in expiration. Okay, turned blue. Okay, and then there was this tonic phase. Okay, what happens is most of the times when we get parental video, the first part is usually missed, and what is shown to us is the last part. Okay, wherein we find the tonic posturing and the jerking of limbs, and thereby we can misdiagnose this as a true seizures. Okay, in each of these episodes, child had first cried for some episode, then held the breath in expiration, turned blue, then there is loss of consciousness and had few limb jerks. Child recovers completely after the episode. Okay, so this is not a seizure but a case of breath holding spell, and what we found at the end of the event was the reflex anoxic seizure. So a good history is a must for diagnosis of epilepsy as well as for epilepsy mimics. Always ask what the child was doing before the episode, what happened during the episode, and what happened after the episode, and that will take you to the right diagnosis. So breath holding spells are very common, but they are very frightening to parents and others observing an episode. Many of them think that they almost lost their child in this episode, so they are so scared. And it's important to differentiate these episodes from epileptic seizures, because we need to avoid inappropriate use of anti-seizure medication in these disorders. Depending upon, actually, breath holding is a misnomer. It implies that the child is holding his breath in prolonged inspiration, like what we do when we are asked to hold the breath. But the fact is, in BHS, the breath is held at the end of expiration, and most of them are involuntary. It's very common. It is seen in 4 to 5% of children, and the typical age of onset is between 6 months to 18 months. But there are few cases which can start even in the neonatal period also, and almost 10% of them can have an onset after 2 years of age. Frequency can vary from several times daily to once in a year. Frequency increases to several per day during the second year of life, and most of the time by 2 to 3 years of age it will stop. They are non-volitional and cannot be equated to with a temperamentally difficult child. Depending upon the color change during the event, we have got cyanotic breath holding spell and a pallid breath holding spell. Okay, cyanotic breath holding spells are more common. They're precipitated by emotional stimuli such as anger or frustration. The child usually cries vigorously for 15 seconds, then becomes silent. You can see here, child is crying here. Okay, then the baby holds his breath in expiration, then turns blue. This cyanosis is very typical in these events. The APN is followed by rapid onset cyanosis, and some of them develop a brief epilepsy with opisternal posturing or few jerks. The key thing is they recover within a minute, and again child will become active. In the palliative spell, they're usually provoked by sudden fright or pain. Usually, the presenting event is a fall with a minor injury to the head. An unexpected event or surprise can also trigger a spell. The child may grasp and cry, and then becomes quiet, loses consciousness, and become pale. Unlike a cyanotic here, the baby becomes pale. They can have limpness and diaphoresis also. And few of them can have chronic movement of the extremities, and up to 10% can have incontinence also. So the presence of chronic movements and incontinence should not make us think that it is a true seizure. Again, the key here is they recover quite quickly within less than a minute, and after the recovery, they may go to sleep for several hours later. Some of them can have both sinuses and pallor, and we call them as mixed spells. Outcome is very good. Most of them stop by 4 to 8 years of age, 50% by 4 years, and almost all by 8 years of age. 1/3 of them can develop syncope in future. Serious complications are exceedingly rare in this condition. Most of them do not need any investigations. A detailed history and review of home videos is sufficient in most of them. The onset of the event is most important. As I told, always ask the child or parent what was the child doing before the episode, and that will give the diagnosis. No lab test is required. But sometimes when we see, when we do not have any first-hand informant, or when we see the video with these chronic drugs, usually EEG is requested, and but EEG will not give any diagnosis. EEG is done especially when the clinical activity is prolonged and the clinical disease is not complete. When you do EEG, you can always do ocular compression during the record. Especially in children with palliative spells, when you do ocular compression, we find that you can have bradycardia or even cardiac asystoly with slowing or suppression of the voltage on EEG. So this can be a clue towards a breath-holding spell rather than a seizure. Rather than EEG, most of these children should have a ECG, because long QT syndrome can really mimic breath-holding spells. Here, the events occur especially by injury, fright, or excitement. So instead of an EEG, ECG should be done in all children with breath-holding spells, especially those with frequent breath-holding spells, because this long QT syndrome can be fatal. How to treat this? As I told, they're benign, so they need reassurance. You need to tell them that there's no risk of intellectual disability or epilepsy, and we need not pick up the child in the event. And on the contrary, you should place them in lateral or recumbent position. If you pick up the child on your shoulder, there is again increased hypoxia to the brain, and that can prolong the event. Do not do CPR, and not to alter customary discipline training for fear of triggering an epilepsy. Very important. You should tell the parents not to give laxity to these kids. Otherwise, these kids become more stubborn. And more than child, we need to give support to the parents. Many of these parents have seen the child hunger spell, and they think that their child is going to die during this episode. Okay, so the parents need to be given more support, and sometimes we may need to refer this the parents to our psychiatric colleagues also, so that they can reassure them. Iron supplementation has got a role in breath-holding spell, and we treat them with iron even when there is no anemia. Treatment for about 4 to 8 weeks is really known to reduce the severity of spells and even the frequency of breath-holding spells. There has been role of even piracetam in breath-holding spell. It is used at a dose of 40 to 100 mg per kg per day. Other drugs which are used are fluoxetine and risperidone. Risperidone drug has been especially helpful when we have children with temper tantrums. For palliative spells, use of theophylline and glycoprid has been advocated. Sometimes atropine can also be used. However, there is no role for anti-seizure medications. This term reflex anoxic seizure is used when we have tonic posturing or tonic jerks in a non-epileptic event that results from cardiac asystoly of vagal origin. Pain and surprise are the common provoking factors. Can happen with breath-holding spell, sometimes after a venipuncture, intramuscular injection, or even seeing an IV drip being put. Can also happen after syncope, cyanotic breath-holding spell, and after any event that results in sudden reduction of cerebral perfusion or hypoxia. And there is one more term called as anoxic epileptic seizures. Many senior pediatricians in the delegates might have seen children who have a breath-holding spell, but they do have a typical convulsive movement which goes on for a couple of minutes. Like in anoxic reflex anoxic seizure, it lasts only for a few seconds. Okay, there are few babies who after a spell can have prolonged seizure, and even status after this breath-holding spell, and they're called as anoxic epileptic seizures. It is presumed that these children have a lower seizure threshold, and that hypoxia ischemia caused by the breath-holding spell can trigger the seizure in this condition. Okay. Here, the anti-seizure medication can abort this seizure, not prevent the recurrent breath-holding spells. Now we move on to another common seizure mimics. Okay, so this child, when a baby goes to sleep, has this head banging movement. Okay, it keeps on going on for minutes to hours, and it's very painful to see their child having this movement. And many parents do not sleep during the night seeing the child having this episode. Okay, what is this? This is called as head banging or rhythmic parasomnias. It occurs in as the infant goes to sleep, and usually there's no any emotional disturbance like anxiety or frustration. It is typical in stage 2 of sleep and can be associated with other rhythmic movements of the neck and trunk like head rolling, body rocking, and leg banging. There no treatment is required, but if their movements are very violent, we can use low dose clonazepam for 1 to 2 months. It's also called as jactatio capitis nocturna, and this head banging and other rhythmic movements of the neck, body, and legs can be all clubbed into a group called as rhythmic and stereotypic movements. Sometimes we have this typical side-to-side head shaking movement, which can be seen in otherwise normally developing children. Okay, they just need reassurance, and as the kids grow older, this will stop. Now we see another case which was mentioned even by Dr. Gosavi also. Most of them present in the neonatal period with tonic spasms. Okay, and many of them are mistaken for tonic seizures. They usually triggered by touch or a loud sound or when they're handled. Okay, and he described it as hyperacplexia. So the important clue to diagnose hyperacplexia is by doing this nose tap test. Okay, either tap the nose. No, you can see these children have got this startle-like response. Okay, moment you touch the nose or the mouth, they have this jerking of the limbs, and they don't habituate. Okay, normally also we can get this response, but within the second or the third tap, we get habituated and we stop jerking. Whereas in hyperplasia, there is no habituation and the jerking continues. Okay. So this is another video. You can see every time the examiner is stopping the nose, child has got these jerks. And when we do a corresponding EEG, there is any abnormality of the EEG. So it means it is a non-epileptic event. This is the hyperacplexia, nothing called as startle responses. It's a neurogenetic disorder, usually autosomal dominantly inherited. And the characterized by neonatal onset tonic spasms, especially when handled in the major form. In the minor form, it can present as excessive and persistent startle response. Many of them have nocturnal myoclonic jerks, and this nose tapping test is a diagnostic, and there is no habituation. The stiffness decreases during the first year of life and disappears by 2 to 5 years of age. And during this time, they may have to be treated with clonazepam. Clonazepam has got the best response as compared to other benzodiazepines. And sometimes, if it doesn't respond to clonazepam, we may have to add valproate also. We do have this type of movements in many children who are intellectually disabled. Okay, they have this head banging movement or this side-to-side body movement, clapping movement. Okay. Their patterned repetitive movements, same form, occur multiple times in a day. Can be seen in normal children, but typically occur in children with autism or with GDD and intellectual disability. They can inform head banging, rolling, body rocking. When very frequent, clomipramine can be used in some of these patients with some success. Okay. This child with autism who has this chest banging movements. These are two children with microcephaly and developmental disability about this rhythmic movement. Okay. They're also called as complex motor stereotypies. Okay. They're not seizures, and we need not investigate them with EEG and put them on anti-seizure medications. This is another interesting child. Okay. This child, 6-month-old baby, normally developing, came up with this head nodding movements. Okay, you can see this. This child used to have cluster of this neck drop. Okay, I'll just play it again. You can see child is playing, looking active around. Okay, then has this head nodding movements. Okay, so these head nodding movements typically mimic because they occur in clusters. They can be confused for epileptic spasms. Like this child was suspected to have spasms by the pediatrician and was referred for a video EEG. And during the video EEG, we were fortunate to have an episode. Okay, this child had this head nod movement, but the corresponding EEG was totally normal. In West syndrome, along with these spasms, you should have hypsarrhythmia. Okay, the ecology being normal ruled out hypsarrhythmia. So this was a case of benign myoclonus of infancy. They are present with bursts of flexor, less commonly extensor movement of the neck, trunk, and arms. They resemble spasms, but key thing is the EEG is normal here, and there is no increased risk of epilepsy in this group of condition. Now we go to another child, a 2-year-old child who had episodes of leg adduction, grunting lasting for 5 to 20 minutes since 5 months of age. Child remained conscious during these episodes, and the episodes occurred especially when she was sleepy or tired. Okay, you can see this video. Child has this adduction of the hips. She keeps rubbing her ankles. Okay, and has this pelvic movements. And few of these children can also have profuse sweating during these episodes, but they are conscious. And the moment you divert them or you pick them up, they will stop. Okay, this is a 8-month-old infant who has this typical adduction of hips, okay, and rubbing of the ankles. Okay, but the child is totally conscious. Okay, can be diverted, and if you pick them up, this movement will totally stop. Any guesses as to what it is? These are examples of self-gratification disorder or infantile masturbation. The onset is usually between 3 months to 3 years. 3 months to 3 years, and there are stereotyped episodes of variable duration. Vocalization with quiet grunting is common. They can be associated with sweating and facial flushing. They have this pressure on the perineum with characteristic posturing of lower extremities. As I told, there is no loss of consciousness, and they stop with distraction. They have a normal examination, normal development, and the workup will be negative. Okay, if there is frequent in the beginning, we can definitely rule out a urinary tract infection or rule out any worm infestation. But other than these two, there is no need to investigate them with imaging or EEG, and they do not need any anti-epileptic medications. Important to note that it can last up to 3 to 5 years of age also. So we need to counsel the parents that this can continue till 3 to 5 years of age, and they need not panic about these episodes. Now we see a few of the movement disorders in pediatrics which can mimic epilepsy. This is a child, 3-year-old child who had this type of neck movements. Okay. Repeat again. Yeah, this side neck jerking movement. Okay. It can affect one or more muscle groups. They can be migratory in severe cases. You can see this. These are typical neck movements. Okay, this child used to have. Okay. They usually affect the face and the neck. We call it simple when the same movement involving one or two group of muscles is there, and we call it complex when it is the complicated movements affect more than 2 group of muscles. They can be in the form of just eye blinking, okay, or making facial grimaces. Okay. Sometimes we have children can make this type of sounds also. You can see this. He's making vocalization. Okay. These sounds. Okay. These sounds can be indicative of a vocal tics. Okay. All these 3 videos indicated tics. Okay. It's important to note that almost 20% of children are affected with tics in some time during their childhood. They're usually caused or worsened by stress. Face and the neck is most commonly involved. It can be in form of eye blinking, facial features, shrugging of shoulders, head turning, sniffing, grunting, or throat clearing. It usually subsides within weeks to months, but they tend to recur for a brief period during infections. When a child has got multiple motor tics and one or more vocal tics for more than 1 year, then we should consider Tourette syndrome. Most of them don't need any treatment, but if they're very frequent, troublesome, affecting the child's schooling, then we may have to use risperidone or olanzapine or clonidine. These are the movement disorders like dystonia, which can mimic a tonic seizure. Okay, this is a child with dystonic CP who's got opisthonous posturing. Okay, and this can be confused for a tonic seizure. The key thing is there is no any uprolling of eyeballs. If it's a generalized tonic seizure, they will have uprolling of eyeballs, and when you do a EEG, the EEG will be normal in this dystonia. Okay, this is another child with dystonic storm. Okay, who has this opistonic posturing of limbs. Okay, many parents don't know this, and they just say that child has got a fit. Okay, so it's our duty to review the video or look at the child, okay, and then diagnose the seizure. This is a child with this type of jerking rhythmic movement affecting all the four limbs. This is a case of child cerebral palsy with severe spasticity who had this spontaneous slowness in the upper limbs. Okay, but the parent will present to us as seizures. Okay, this is a child with dystonic storm. Okay, who had this dystonic tremors in the upper limb with this protruded tongue. Okay, so most of these movement disorders can mimic seizure. This is another 8-month-old baby who was referred to as focal seizures, exclusively breastfed, and had his abnormal movement of fingers for last 2 to 3 weeks. You can see this tremulous in the hands, okay, both the hands and even in the feet also, okay, can affect even the tongue also. Okay, important to note the child is conscious during these movements, and it continues for hours together. So that makes seizure very, very unlikely, and the child is very irritable here. Okay, the other clues like hair is a bit hyperpigmented, and there is knuckle pigmentation. Okay, I'm sure all of you have made the right guess. It was a case of infantile tremor syndrome, and usually we do serum vitamin B12 levels peripheral smear and start them in vitamin B12. It's important to note that once we start vitamin B12, these movements can increase. After we start supplementation vitamin B12, for 2 to 3 weeks, movements can increase. It's very important that we counsel the parents about the transient worsening which can happen with the therapy. Otherwise, many parents will be upset that by treating, we have worsened these movements. Some of these seizure mimics occur during sleep, and when they occur during sleep, we call it parasomnias. We have many parasomnias like sleepwalking, sleep talking, night terror, nightmares. Okay, they occur during sleep. Okay, so this is a child whose video EEG was being done, and during the record, she was sleeping and she got up and she had these violent movements. Okay, so if you look at this video, they don't look like a seizure because it's violent, very bizarre movements. Okay, but when you do a video EEG, we do find that this is a typical of a frontal lobe seizures. Okay, so frontal lobe seizures usually happen during sleep. They're very brief and they can have bizarre movements. Okay, looking at the video, it looks more like a seizure mimic, but this is a true seizure. Okay, this is a table which helps us to distinguish frontal lobe seizures from parasomnia. Frontal lobe seizures usually happen during sleep in the childhood. They're stereotyped and very short, up to less than a minute usually. They can be frequent and occur during the anytime during sleep, whereas parasomnia are very common in the initial part of sleep, that is NREM, and REM parasomnia are usually in the late part of the sleep. Now we move to another case. This is a 10-year-old girl. Another one of the common scenarios. Child is brought by parents with history of loss of consciousness in school and a fall. Teacher and friends had noted that she had abnormal jerking of all her limbs for a few seconds after she fell. Okay. When you have this scenario with LOC followed by abnormal jerking of limbs, what should be the next question? Okay. Like I told earlier, you should always ask what the child was doing before the event. Okay. So in this case, child was standing in the assembly for about 30 minutes before this event. Okay. So what is the likely diagnosis? Is it syncope or a seizure? Looks like syncope because child was standing in the assembly and had this fall with LOC. But she also had this jerking of limbs. That's what was concerning the teachers, because the teachers told the parents that they had seen few children with seizures, and this child definitely had a seizure. Okay. The child was flaccid, motionless, had a loss of consciousness lasting for seconds to minutes, but the recovery is very dramatic also, and these tonic jerks. Okay. So again, they told in reflex seizures, convulsive movements can occur in up to 40 to 60% of cases of syncope. Almost 50% of children with syncope can have few tonic jerks. Okay, so just because this child has got tonic jerks, we should not diagnose a seizure. Okay, the motor symptoms of syncope are clonic or myoclonic-like, and sometimes we can have tonic flexion or extension. They either usually open with upholding of eyeballs, and sometimes they can be lateral deviation also. They tend to last only for a few seconds and terminate once the patient is horizontal. As soon as the child falls, within a couple of seconds, this jerks will stop. How to distinguish syncope from seizures? The setting. Usually it happens in crowded settings when child is standing for more than a few minutes. Okay, most of them will have nausea or sweating before the event, and the recovery after the event is very quick. In less than a minute, child will be conscious in syncope. Unlike a seizure, wherein child can be in post-ictal confusion for a few minutes to an hour also. Injuries like tongue bite, if present, can favor seizure, but rare case of syncope can also have tongue bite. Incontinence is rare in syncope, common in seizures, but 10% of children with syncope can have incontinence also. Okay, so we look at the entire case and then make a distinction. How do you treat syncope? We need to counsel the parents, ensure plenty of water, avoid fasting, avoid crowded places, prolonged standing or sudden postural changes, and increase salt intake in the diet. The role of drugs, you can use beta blockers, anticholinergics, alpha-adrenergic drugs, serotonin reuptake inhibitors like fluoxetine, and mineralocorticoids like fludrocortisone. Okay. Out of all the drugs available, midodrine at a dose of 5 to 10 mg given thrice a day is found to be of great use in children with frequent syncopal episodes. Okay. Now we come to the last scenario. This is an 8-year-old boy who presents with seizures for the last 2 months. Okay, this type of generalized movements. Okay, affecting all the 4 limbs. Okay, this was a child who had hyperactivity and had poor school performance. Multiple episodes occurred during the daytime. No episode during the night. Had already visited 3 doctors and was on almost 3 to 4 drugs. MRI done was normal. 2 EEGs were normal. Uncle was an epileptic on treatment, and the entire family was anxious because of these frequent events in the last 2 months. Okay. Any guesses as to what is this? This is a case of pseudo seizure. Okay, also called as paroxysmal non-epileptic event. Okay, if you look at this video, this child has got jerking of the limbs, but they're not synchronous. Okay, look at the eyes. Eyes are closed. Okay, so this is a case of pseudo seizure, not a true seizure. Okay. In many of these psychotic non-epileptic seizures, you can even provoke these episodes also. Like in this child who came to my OPD and had this event in my OPD. Okay, when I asked the father, he always said that whenever we touch his head, he gets this episode. So I asked the father to demonstrate that to me. Okay, you can see the child is sitting now. The father touches the head and he has this episode. Okay. Again, I asked him to repeat that again. Okay, so every time the father touches the child's head, he has an episode. Okay, so this provocation can be a pointer towards a psychogenic non-epileptic event. Okay, sometimes we use a tuning fork to provoke these episodes. So if you can provoke an episode in your OPD, then seizure is very, very unlikely. Many of these children have got psychological stress or trauma. There can be history of sexual abuse, and the event usually occurred in stressful situations. And there is no effect of anti-epileptic drugs in this condition, and there can be history of physical abuse also. If you look at the events, okay, most of the time the child has got closed eyes, and when you try to open the eyes, there is resistance to eye opening, and it lacks stereotypicity, and they have avoidance or guarding behavior during this episode. And events usually occur in the presence of others, never when they're alone. And injuries are rare during the episode. Okay, you don't have a tongue bite, you don't have incontinence during these episodes, and there is an absence of post-ictal confusion in these episodes. So psychogenic non-epileptic events are most common cause of epilepsy misdiagnosis. Helpful with historical features include bizarre immunological features like we saw in the first video. They always occur when awake in the presence of others. They're resistant to AEDs. Okay, if it is true epilepsy, it should show some response to anti-epileptic drugs, but here they are resistant to AEDs, and there can be specific triggers like stress or pain. It's important to note that many children with true epilepsy can also have psychogenic non-epileptic seizures. So both can coexist. So if you have a child with epilepsy and has got some events which do not like seizures, then they could be psychogenic non-epileptic events. So both have to be tackled differently. Epilepsy with anti-seizure medications and psychogenic non-epileptic with counseling. Okay. It's important to note that they are not consciously producing them or controlling them. Okay, so it's not malingering here. Okay, there is some underlying stress in the child which is making the child do it. Okay, so they're not malingering or not doing it purposefully. So don't tell them that this child is doing natak, or don't use the word like natak karai karke, because when we say this, no, parents will start again causing more trauma to the child, and the events can worsen. Okay. So I would like to conclude by these following key messages. All that shakes is not epilepsy. So many examples I saw. All of them mimic seizures, but they're not epileptic seizures. A good history is a must for appropriate diagnosis, especially the circumstances. What happened? What was the child doing before the episode? The description of the episode and what happened after the event. Okay. If you take a detailed history, you can make a clear diagnosis in majority of these seizure mimics. And try to witness the event. Okay. So always ask for home videos. You can do suggestion like shown in the second video. Okay. And if you don't have home videos, don't hurry in starting anti-seizure medications. You can always wait. There's no hurry to start medicines or doing test. You can always tell the mother that you please go back home, get me some videos. We will review the videos and then consider treatment. Investigations are seldom helpful in this group of disorders. Routine EEG is not helpful in ruling out epilepsy. And in these cases, video EEG is very helpful because you can have corresponding video along with the EEG. You can diagnose most of these conditions correctly. Thank you.
Thank you very much, Dr. Mahesh. It was indeed a wonderful session covering almost all types of non-epileptic events or seizure mimics. I think if pediatricians and pediatric neurologists, even general physicians, if they remember what they see visually, I think nothing like it. So misdiagnosis is a huge problem. So many times they're on medications for years.
Dr. Konaki, your voice is a little low.
Audible now? Okay. So it was a wonderful session, Dr. Mahesh.
Thank you. Thank you, Ramesh. Thank you.
We can move to the quiz quickly.
Yeah.
Yeah, Badal sir, you are here?
Yeah. Good evening, everyone. So we move on to the quiz. Nityaji, can we have the quiz rules?
Yes, sir.
So as ma'am has told that we are going to extend the 2 more sessions. So this is not going to be the last quiz trivia. Next slide, please. So just ensure that you have a good internet connection. All the 3 categories can participate again. There is the pediatric residents, the practicing pediatricians, and pediatric neurology trainees. The only point which we want to make sure is that the prizes would be given to all the 3 categories in every single Sunday quiz trivia. However, only practicing pediatricians and pediatric residents would qualify to be going for the grand finale. Next slide. So to be very honest, the platform for this is very, very simple. You need not do anything. The moment we say that the quiz is open, you'll get the link in the chat box, and that link can be started off immediately. And those questions would be approximately 15 questions. All will have 4 answers. Only 1 will be correct. No negative marks. Only what we require from you is your category should be very, very clear. Like if Mr. Rahul Verma is a PG resident, he has to write as a prefix like PG Rahul Verma. If he is a pediatric practitioner, then PP Rahul Verma. And if he's a pediatric neurology trainee, then he writes a PN. Those people who are not going to enter this prefix for the category will not be considered for the prizes. And you might find certain questions with an image, but this time we haven't kept those images. So we just go on to the quiz straight away. Next slide. So Nityaji, please post the quiz link to the chat box.
Yes,
the quiz will last approximately 4 to 5 minutes, and we will close the quiz by the time
I have given it in chat box, and also I am putting it in YouTube.
So all the best for the competitors.
So now we are available both in YouTube and here also, and I'm showing you the progression of this quiz. So this is the progress of our quiz. Till now we can see 5 people has already completed.
So last 30 seconds to complete the quiz. Okay, last 10 seconds. So Nitya ji, just close the quiz and take the result sheet out. No one after this should be entertained after closing the quiz.
So now quiz is over.
Yeah. So can we go on to discuss the questions, quiz questions? By the time we prepare the results?
No, Dr. Badal, no, we'll have the Q&A first, right? We'll
Okay,
come to the
ma'am.
quiz in the end.
Okay, ma'am. Okay, ma'am.
Dr. Talukdar and Dr. Ramesh will continue with the Q&A. Yeah.
Over to sir.
Okay. First to Dr. Goswami. I hope my audio is clear. First question is,
Yes.
how does Stiffman syndrome manifest in utero?
Stiffman syndrome can manifest in utero. There has been cases just like your, there can be intermittent tonic posturing. So this can be appreciated as literature says that it can be appreciated as abnormal movements in utero rarely. Can be as early as in utero.
Okay, thank you. So other common question, most of the pediatricians are often confused because many centers do not have an EEG. So the question is, subtle seizures don't usually have EEG correlate. So should they be considered as non-epileptic and should we treat or not?
Yeah, I have answered this in the chat box. Subtle seizures, many of them are non-epileptic. Hence, they are not to be treated. However, there is a concept, there used to be a concept of subcortical seizures. So probably now they know that they are mostly due to other autonomic dysfunction due to other reasons. So they need to be followed up closely. And in case it is not causing any hemodynamic decompensation or anything like that, no tachycardia, then no drugs to be started.
Right.
Although supple seizures are usually considered supple, this term probably coined by Volpe initially, there are cases which really ultimately turn out to be epileptic. They do show easy abnormalities. So it is
Yes.
not that all supple seizures are really benign.
Yes.
Then I saw in one of our projections there is a stroke incidence is about 20%. It's a very high incidence. Where did you can I get the
Sir, this has been taken from a Western literature, as in the Cloherty and Stark textbook of pediatrics. It was based on a study which was published in American Academy of Pediatrics. However, probably in India, infections might be more common,
yeah,
sir.
we did not do so much of strokes. Probably in our setup, the primary etiology is the HI, followed by metabolic disorders and so on.
Yes.
There is one problem we frequently face. It looks like seizure. EEG is normal. What to do?
They are number one. Now the reliance is more on EEG. So in case their EEG is normal, it looks like seizure. Keep the baby on close follow-up. Ask the parents to come back again with videos, but not to start anti-epileptic drugs.
Yeah, better to follow them up. Many times diagnosis comes up after a little bit of follow-up, not
Yes,
right
sir.
at the beginning.
Yes, sir.
Another thing, a child, a newborn baby, he has seizures. It looks a very clear seizure. EEG also shows electrophysical abnormalities. Etiologically, you find the same baby had HI, features of HI in MRI. He had a little bit of hypoglycemia. He had a hypoxic ischemic encephalopathy, hypoxia, and there is a small cyst. Now, what etiology you will like to fix in this particular baby?
It is here, sir. It is difficult to say. Probably both of them, hypoglycemia and
very
HI.
common situation in our country.
Yes, sir. Yes, sir. So, but in both of them, we need to continue the anti-epileptic drugs. Probably the child will have long-term seizures, which are quite high.
My question is, which you think to be the cause of epilepsy, cause of the seizures in this particular case? When there are more than one factors, all are epileptogenic.
It is difficult to say. Hypoglycemia is a very strong.
Hypoglycemia, and these are very common in HI babies who simultaneously get hypoglycemia,
Yes,
but common. So this is a very big problem in our setup. I think we should study this. Younger people, younger generation, you should take up these studies. Let us see. Even multivariate analysis also probably cannot pinpoint which could be the primary factor.
Yes, sir.
Right. Any other question?
Yes, sir. There are a few more questions. What is the ideal time to get neuroimaging in a newborn with HIE with ongoing seizures?
Yes, sir. The reason for getting a neuroimaging is basically for prognostication. So in our setup, if a baby is well, going home on discharge, that is the time before he goes home. And if a child is very unwell, you need to prognosticate. Then whenever the baby is stable for MRI, you need to get it. There have been certain studies, mostly in hypothermia in HIE, which have found that one has been published in, I think, BMC Pediatrics, which have basically shown third day to sixth day to be the optimum time for MRI in our setup before discharge.
Right. I think that's the time when maximal cerebral edema and full extent of lesions can be appreciated best. Then what will be the best first-line drug for preterm babies? And if they're not controlled with phenobarbital, what is the second line we must consider? Preterm babies.
Now this is a very tricky question. Actually, now there is a shift towards levetiracetam. Though we cannot recommend it as of now, levetiracetam and topiramate, but we cannot recommend as of now. So we have to go towards phenobarbital only. I'd like to take the opinion of the other.
Yeah, you're very correct. The trials are going on. Sometimes they do quite well. Result is quite good with levetiracetam as well as topiramate as well. But still, at this stage, probably it is difficult to say which should be best drug. Probably we have to fall back to phenobarb only right now.
Yes, I think we need to balance side effects also very important in preterm
Yeah,
patients,
yeah, very
because
correct.
they already tend to have a lot of apneas. With phenobarbital, there's a high risk that they may go into prolonged apneas requiring mechanical ventilation. So yeah, although we don't have a clear answer, maybe if they're easily controllable, easily controlled, maybe levetiracetam can be considered in the beginning.
But nowadays, with good ICU setup, we very rarely come across in reviving a child, bringing back a child if he has developed serious apnea. No, it is not a problem nowadays in pediatric ICUs and ICUs.
Yes, another I think $1 million question. Recently, some data has come up through good observational study in a newborn who had neonatal seizures. Now follow up at 3 months, no seizures, phenobarbital tapered and stopped. So there one question is when to stop, early versus delayed discontinuation. Second question is if the same child after stopping AEDs, say 3 month, 4 month again seizure recurs, should we restart the drug which we had used earlier, like phenobarbital, or should we switch to some other drug? So two questions.
So in the case of mild to moderate HI, ideally what now the thought process is that the baby should go home without an AED. The AED should be stopped before he goes home. And number two is if a baby has seizures after 3 months on stoppage, then instead of phenobarb, an alternative drug should be thought of, probably. There again, we don't have a consensus, but then starting of phenobarbital with what has been brought out, neurodevelopmental effects.
Yeah,
Right.
probably
All,
better to avoid phenobarbital.
Yes. I think all neonatologists and pediatricians who are managing babies with HIE and subsequently should remember that as a principle, try to taper antiepileptics as early as possible in all the newborns. That has to be the principle. And only
Yeah, it is
those
already being
cases
done.
where, yes, sir, very difficult to control refractory seizures, maybe you can take little longer. So as a principle, the earlier you withdraw, better.
Yeah.
Ramesh, if you can make a point, especially in neonates who have otherwise normal antenatal and birth history and who do have recurrent seizures starting in the first couple of days, no, when our drugs like phenobarbital and levetiracetam fail, we should never forget to think of even channelopathies, especially casein Q2 and sodium SN88A, who can come with neonatal seizures and they beautifully respond to phenytoin. So nowadays, what happens is we are moving away from phenytoin, and we are missing many of these genetic. I agree they're rare, but when other lines fail, no, we should always give a therapeutic trial with sodium channel phenytoin before we think of other rare condition and other treatment.
Yeah, in fact, phenytoin was in only one RCT till date. It was equally effective as phenobarbital.
Yeah,
as
because of the kinetic profile, it was sidelined, but it was equally good. Okay. This is to Dr. Mahesh. Can breath holding spell be present even without iron deficiency anemia and ECG normal? I think you answered that in the talk itself.
Yeah.
Should all children with breath holding spells be treated with paracetam?
No, not all. The first line would be to use just simple iron and counseling. Okay, but if the episodes continue despite treatment with iron, then we can give a trial of paracetam.
Okay, right. Again, coming back to Dr. Goswami, newborn seizures, lip smacking, sucking with persistent cry. How to differentiate hunger cry and seizures? Is glabella tap useful?
This again is a bouncer. Actually, hunger cry would the baby would be satisfied once you give the feed, and it will stop. That is the only one I can think of. And the baby.
Yeah, very correct. Hunger cry is recognized very moderate. There is no need of the physician.
So
mother recognizes it very well. Give the child a feed and it becomes okay.
Globular type has got no, globular type I think is something which has been mixed up here. There's no.
One can make out what is the country. Dr. Mahesh, in your practice, what is feel to be the most common seizure mimickers in our country, in our setup?
I would say breath only spell in beyond neonatal period, sir. And in young infants, benign sleep myoclonus. These two are the most common. Breath only spell is very common, sir. Older kids, I would say syncope, sir. Syncope.
Very correct. But breath holding spell, it is often comes into the area of seizure mimickers. But it is really very difficult to exclude. Is it really very difficult to exclude breath holding spell?
But history, sir, history. Most of parents say that child has the posturing of limbs, and they already about that posturing of limbs and the jerks. Like they don't tell what happened before the event started. So that history taking is very important. Like so, in a busy OPD, many pediatricians don't take that history, and in that bargain they miss the diagnosis of breath holding spell.
All right. It is nice to find that you have brought out a lot of behavior disorders in your earliest groups, 3 to 4 years, 1, 2, 3, 4, 5 years, which usually we neglect.
Yes.
We usually forget. It's very nice that you have brought those out.
Thank you.
In your talk. Good.
What is the role of benzodiazepines in acute neonatal seizures?
Yeah, benzodiazepines definitely have a role because acute seizure control is established. Among the benzodiazepines, lorazepam has got good lipid solubility, it is better. And diazepam displaces bilirubin, that is another thing, it can lead to hyperbilirubinemia, it causes more respiratory depression. However, the half-life is long, it goes up to 30 hours or even more. So repeat doses is maybe problematic, but acute seizure control, definitely.
Okay.
As a one-time management, it is an excellent drug, there is no doubt. In fact, when a child is seizuring actively, whatever you get, take it and push it. There is nothing, no need to wait.
Dr. Mahesh, what is the management of refractory non-epileptic events? Probably they meant refractory psychogenic non-epileptic events.
Yeah, it's a very tough question to answer. And basically, like here, we need to take a good history, and counseling of parents is very, very important. We need to counsel the parents that it is not a seizure, and it doesn't need anti-seizure medications. Okay, this is one answer we need to tell all the parents, because many parents are not happy with one physician. They just move on to another physician and get another set of tests. And we need to tell them that they are not true seizures, and they're not harmful. They don't cause any harm to the baby, both cognitively or to the life also. And once we reassure these 2 points, then we need to really go to the bottom of the cause of these events. Usually, they have a lot of other factors, like in my practice, at least many kids I found that they have underlying dyslexia, ADHD, scholastic performance, pressure from the parent to do well at school. And these issues, unless we tackle them, this child is going to come back with some other event. This it may stop with non-epileptic event, but they may come with some pain abdomen or headache or some other somatic complaints. So we need to go to the bottom of the cause of this event and then tackle that. But key thing is that we need to tell the parent that the child is not doing it purposefully. Sometimes we loosely use the term natak kar raha hai. Once we say natak kar raha hai, parents they get all the more angry with the child, and they start what you call abusing the child at home. And that can aggravate the stress, and the child can have more problems actually. So the thing to tell is that the child is not doing it purposefully, and there's some underlying stress, and that has to be solved. Both the parents, doctors, school people, friends, all have to come into the picture and do their part.
Right.
Important thing that one we need to do is give more time to the family to explain.
Yeah, that's true.
That's the only thing.
Yeah.
No, if there is no question, over to Dr. Shefali.
Yeah.
How to differentiate infantile gratification from dystonia?
Just repeat.
How to differentiate gratification from dystonias?
Dystonia. The setting, the pattern of movements are typical. In infantile gratification, there is adduction of hips, there is rubbing of the ankles, and there can be some pressure over the perineum. Child has a lot of profuse sweating, and it will be there for a couple of minutes and it will disappear. And child is conscious during the episode, and we can distract it completely. The moment you pick up the baby, you distract, it will stop. The dystonia is a abnormal movement wherein the twisting of limbs. There is variable tone, and it is intermittent in nature.
I think this is the last question for today. I think this is very important that we clarify. So the question is, the child has breath holding spells and EEG is abnormal.
You should ignore the EEG. That's it. Don't look at the EEG. Clinical diagnosis is of paramount importance. So diagnosis is breath holding spell. No matter what the EEG is, we should ignore it.
It's a clinical diagnosis.
Yeah, don't do EEG. If
Yeah.
the clinical diagnosis is breath holding
Don't
spell,
do it
don't
with
EEG.
this. No need.
Yeah.
So, Dr. Shefali, I think,
Can we have, yeah, thank you, sir. Thank you very much. Dr. Badal, can we have the answers? And before we have the results of the quiz, can we have the answers of the quiz questions?
Sure, ma'am.
Oh, sure.
Nityaji, please go ahead with the Firebox platform.
Yes, sir.
And today it seems somebody has got a hat trick, huh?
Yes, ma'am. The results should be soon displayed.
Yeah, I know. I have it on my WhatsApp, so I can.
better keep it secret.
Yeah, no, Badal. It is Badal's prerogative. Dr. Badal is on this.
Sure, ma'am. Nityaji, please put it on the Firebox platform.
Yeah, just 1 minute, sir.
So we try to keep few easy questions and few not so easy questions. So let's see what things are.
Yeah, Badal sir, over to you. Can you hear me?
Yeah. Start the quiz. Yeah. First question was, which of the following statements is true about the NeoLev-2 multicentric study on neonatal seizures, which this study was also flashed by Dr. Goswami. So the first option is an RCT on efficacy and safety of levetiracetam, phenobarbital, and phenytoin. So this is not correct because it was only for levetiracetam and phenobarbital. Outcome was complete clinical seizure freedom for 24 hours. Again, this was partially correct, but it is not correct because it was the complete electroclinical seizure freedom rather than the clinical electrographic seizure freedom. Third is levetiracetam was more effective, which was not. And the answer is higher rates of adverse effects were noted with phenobarbital. Which among the following syndromes is associated with gelastic cataplexy? So as we know, the cataplexy is a sudden loss of tone, and gelastic is the provocation by laughter. This is a characteristic of Niemann-Pick type C, and it is not all of the above. Next slide. Which among the following genetic variants is not associated with hereditary hyperexia? If you would have seen the slide of Dr. Goswami, he did mention those mutations. As we know, these are glycinergic receptor mutations and certain transportopathies. So GRI1, JLRB, and SLC6A5 are known to cause hyperexia. The answer is PRRT2, which is not the cause for hyperexia. Which salt is FDA approved for cataplexy in children and also notoriously famous as date drug, also as date rape drug rather? The answer is sodium oxybate. Rather, it is the only FDA approved drug for cataplexy in children. Which among the following is not true about hereditary hyperexia? Option 1, it is also called as Koch disease. Yes. Option 2, habituating startle attack easily elicited by finger tap over nose. Yes, it is easily elicited by finger tap over nose, but you would have heard Dr. Kamate sir to have spoken that it is non-habituating. He kept on emphasizing that it is non-habituating. So the answer is habituating should not be there. Vigivano and clonazepam does have an effect. The answer is habituating startle attack easily elicited by finger tap. Yeah. Which of the following hyperkinetic disorders have prominent nocturnal dyskinesias? As the name suggests, PKD, PNKD, and PED, they are all paroxysmal dyskinesias, but they do not have prominent nocturnal dyskinesia. The prominent nocturnal dyskinesia are usually associated with adenine cyclase 5 related dyskinesia, ADCY5. So answer is ADCY5 related dyskinesia. Okay, which paroxysmal disorder is not included as episodic syndromes that may be associated with migraine in ICHT3 for headache disorders? So as with the name suggests, episodic syndromes that may be associated with migraine is a new terminology for migraine variants. If you know the migraine variants in children, the benign paroxysmal torticollis, benign paroxysmal vertigo, abdominal migraine, and childhood cyclical vomiting syndrome are the answers. Spasmus nutans is not included. The answer is spasmus nutans. Paroxysmal extreme pain disorder, previously known as familial rectal pain syndrome. The causative genetic variant is SCN9A. Hypoglycoresia can be seen in which all disorders? So the answer is GLUT1, yes. Hypoglycemia, yes. CNS infections. So answer is all of the above. Which of the following is not a vitamin B6 responsive epilepsies? As the name suggests, FOLR1 defects are folinic acid responsive. So FOLR1 is the answer. Now talking about cerebral folate deficiency, which is not seen in cerebral folate deficiency. Severe MTHFR, FOLR1, CAN-SIRE, X-linked creatine transporter defect. This X-linked creatine transporter defect do not have folate deficiencies. What is not true about breath holding spell? Very nicely talked about, Mahesh sir. They can be pallid or cyanotic. Second is breath holding occurs during inspiration followed by cyanosis in a cyanotic breath holding spell. So it is not in the inspiration, it is during the expiration. Sir had very much emphasized on this particular part. Piracetam and the pathophysiology of pallid spell being a vagal syndrome asystole is correct answer. The actual answer is breath holding spell. B. Breath holding spell. Yeah. So what is not true about benign sleep myoclonus? Again, it was emphasized very nicely. Common in healthy neonates, but not seen in infancy. So it is not like that. It can go way beyond. Usually can be seen about 3 months and even later also. The answer is option 1. What is not true about tics? Stereotyped repetitive movements of more than one muscle group, mostly in upper body, yes. There is an urge associated with the tics, yes. There is a premonitory urge. Voluntary inhibition is not possible. No, it is not like that. The child can voluntarily suppress the tics. So the answer is voluntary inhibition is not possible. And moving on to the last question of the quiz, the genetic epilepsies constitute what percentage of the neonatal seizures? The answer is 1% of all the neonatal seizures. So we have completed, and over to Shefali ma'am for disclosing the names of the winners.
Dr. Badal, you go ahead.
Okay, ma'am.
Names are disclosed by Quizmaster only.
Okay, ma'am.
So you are the Quizmaster.
So, amongst the pediatric residents category, Dr. Arnab Samanta, as ma'am was telling, he has scored a hat trick. His score was 53 out of the 100. So he's from Calcutta National Medical College, and he's the winner for the pediatric resident category. Second is pediatric practitioners. Dr. Sameer Bhatia from Gangaram Hospital is the winner for the pediatric practitioner. Sir would have got advantage by seeing the many genetic variant questions, probably. And of course, the keen listener would definitely get benefit from the presentation. Pediatric neurology trainees, Dr. Sridhar Joshi has again won for the second time after the first trivia. He has scored 86 out of the 100. This is very remarkable. Congratulations, all the winners. We look forward for the next quiz again.
Dr. Badal, Dr. Sameer is also second time, I think.
Yes, ma'am. Yes, ma'am.
Second time.
Yeah, and I just wanted to tell that in the end we will be taking the cumulative scores for the grand finale. So whoever is not coming up also now but is going on competing, so the cumulative scores will be taken for the final quiz, which will be there in person, face to face, and not only on the link. Before we thank you so much, Dr. Badal. Before we end, Dr. Talukdar sir, any take home messages?
It's an excellent, very well arranged, well organized sessions. Both the speakers are very good, projecting very, very clinically relevant matters. It's excellent, very excellent. And questions are also equally good. questions that were put up were really good. And probably, yeah, they're answered well by the speakers. It's nice.
Thank you. Thank you, sir. Dr. Kalra, ma'am, would you like to say something? Dr. Kalra, ma'am? Dr. Kalra, ma'am? Anju, would you like to say something? Dr. Anju? Okay.
Kalra, ma'am,
I would like...
Unmuting.
Hello, hello. Sorry, I've just gone to grab some dinner. Okay.
Ma'am, take home message, ma'am. Ma'am, we had a hat trick this time by 1, and we had second time by 2.
The listeners are very keen listeners. It indicates very clearly. From the presentation, they are picking up the answers extremely well, which indicates the keenness with which they are listening to the talks. And I think the speakers are making equally valid, wonderful presentations, which are rightly very strongly updated in the current context. So I think both sides have a very win-win situation. As far as the distinction between non-seizure and seizure events, I have one very important comment to make. Very frequently in the same child, the two overrun, and we should never forget that. The overrunning between a child having seizures and having non-seizure events of various types in the same history is very common, and therefore we can't afford to miss either the seizures nor the non-seizure events. And we have to keep our minds very open. A child seizure can also have gratification, which is very understandable. A child with breath holding spells can somewhere down the line also turn into true seizures. So I think we have to see all these in an evolutionary phase, and also recognizing that during the phase of evolution, there could be overlap of these, and we'll have to treat the child based on whatever situation he comes to us in. Would you agree with that, Mahmood?
Yes, ma'am. You're right. Absolutely correct, ma'am. It's very common that children with epilepsy have pseudo seizures also, and they have to be treated based on the events. So for epilepsy, we need to treat with anti-epileptic drugs, and for non-epileptic events, they need counseling.
Because it's not as pure as it seems in a talk. That's the point I wish to make to the audience.
Thank you.
Wonderful. It was
the most important.
Yes, Shefali.
Thank you very much, ma'am. Like you're saying, ma'am, this is very, very important that both of them coexisting, and we have seen so many times. And I think they should always ask for the seizure semiology on the mobile, and that will be the most important information we can get rather than any investigation. So when they're asking them to make home videos, I think that is most important, ma'am. I think, don't you think so?
Semiology on the video also at times is very tricky. It depends on how much time has elapsed before the video got recorded. That also becomes tricky at times.
Yeah, but I mean, they should still encourage for the the home videos.
Everyone is a boon, absolute boon.
Yeah, but obviously they have to keep a high index of suspicion for thinking about beyond epilepsy, but always rule out, and I very rightly said, which was missed during the discussion still now, that it can be mixed. It can be both of them coexisting. That was something which was missed out in this thing till now. Thank you so much. Thank you, ma'am. And I'm very grateful to our quiz masters team, Dr. Badal, Dr. Priyanka, and Dr. Ranjit, and the moderators of the whole thing were Dr. Rajiv, Dr. Anup, and Prateek. I'm really grateful to Dr. Talukdar and Dr. Ramesh for chairing and moderating. And obviously the speakers of the day, Dr. Goswami and Dr. Mahesh, thank you very much. And next week we come back. And next week we are going to be having very important certain questions, about one is about the discontinuation of the medications, domiciliary care, what about the adolescent issues, and what is the transitional care, which we don't talk about, and which I think are very, very important for us to understand. And the other thing is non-drug options which are there. And as I mentioned in the beginning, we'll be extending by 2 sessions. One will be on EEG, what a pediatrician should know. And the next, that will be the 7th one. And the 8th one will be partly on neuroimaging and partly on, metabolic, genetic, and autoimmune investigations. What all they will need to know about it. Thank you so much for everything.
Thank you, ma'am.
Thank you,
Thank you so much.
Thanks.
Good night, ma'am.
Thank you. Thank you, ma'am, and thank you all the panelists here and the viewers. Good night,
and
everyone.
thanks BryoBliss, and thanks BryoBliss for all the support, technical support, and always also the prize support for the prize.
Thank you.
Yeah.
Thank you.
Thank you. Thanks.
Thank you.
Thanks.
Good night. Good night.